Maybe we'll go ahead and get started. I want to just welcome you again. I'm Zena Grifoni. I am a physical therapist and Pilates instructor. My base is San Francisco, California area, San Rafael. We have a physical therapy Pilates clinic studio there. I also am living currently in Switzerland and have a little tiny studio here. I'm doing some work around this area as well, teaching a lot of classes online. And typically we have a group that meets. We've been just discussing neuro rehab in this group. We're just about to finish that module and moving on to all other topics. And I was fortunate enough to meet with one of Dr. Ricki Pollycove's clients. I had the privilege to work with her as one of my own clients as well. And she said, you need to talk to Ricki Pollycove. We started talking about menopause and the changes of the body. I had myself a lot of questions about why women suffer physical injury later on, why we see so many more hamstring tears, why we have shoulder issues, why, what can we do about osteoporosis other than try and strengthen people after we know they have osteoporosis and take precautions then. So anyway, I reached out to Dr. Ricki Pollycove and she responded right away and suggested that she could come. I asked if she would mind coming and she openly said, I'd love to come and meet the people that you're reaching out to, and we're hoping to just reach a whole another level of people to share her message. So I'm gonna just turn it over to her. You're welcome to put questions in the chat. She will look at them and I will look at them, and we'll try and keep the flow and keep it as interactive as possible. This is the first of 3 sessions we're going to have. We have the privilege to have with Dr. Pollycove. So this is the first one. Next one will be the first Wednesday of next month. That'd be in May, and then it will be the first Wednesday in June. I believe that's June 1st, all at the same time. So if you could save that time, those times. And in the meantime, if you have questions between sessions, you can also email me and I will see what we can do to make sure your questions get answered. So with that, I'm going to mute myself and turn it over.
Okay, thank you so much. I have been at this a long time and volunteered to start reaching out more actively to the public because I'm so concerned about the fact that by the millions, women arrive at this transition in natural hormone synthesis and are really often quite unprepared and shocked. So my background, fortunately, before I went to medical school, was I was an undergrad at UC Berkeley and got invited to do some research in the mammary tumor virus system in the Cancer Research Genetics Lab, which translates into basically breast cancer research in mice using immune tools. So that turns out to be very relevant since the fear of breast cancer has been such a huge part of the reluctance on the part of the public and providers to really learn about hormone support, especially estradiol, natural estrogen. So I actually was the founding mother of our breast center and the director for education and chief of GYN. The National Consortium of Breast Centers is a body I've belonged to since 1994. I take that very seriously. I'm a fellow of that group, which I think there are about 26 of us who've sort of been at it for so long that they awarded us with that honorary club just as recognition for trying to optimize breast health and reduce risk of getting breast cancer and help facilitate early detection and appropriate treatment. The North American Menopause Society is another area I've been very active. NCMP is the certification for menopause providers. There's an exam you take. I've been clinical faculty at UCSF in both GYN, but more active in psychiatry because of my work with hormones and mood. And lastly, I also am on the board of trustees of the California Institute of Integral Studies, which is a beautiful institute, university that offers all forms of education for the whole person and body, mind, spirit, basically. And co-authored the Integral Health Curriculum. I've co-authored one book, Mother Nurture, which is an ebook now in its 20th year. We're doing an update version for its 20th anniversary, but it's really about self-care during those exciting but often treacherous years of motherhood. And then more recently, the Little Idiot's Pocket Guide to Bioidentical Hormones, to basically, in a very small readable book, bring evidence-based information to millions of women. So let's see now, for whatever reason, there we go. Okay, so I thought we'd touch on the history of humans, including a bit of men, history of hormones, and then what's different between women and men, and some of the early warning signs and symptoms that my hormone landscape is shifting, and how hormones are during the various stages of our lives, with some details and some science. And then lastly, a big part of what those of us who are in various aspects of healthcare, and I certainly consider my physical therapists and Pilates teachers to be very important partners, because we don't exercise, we're not going to like old age. That's my byline. And then working with clinicians, insurance, and then how we ultimately put ourselves in the schedule. So there are a lot of myths, which we've touched upon. I do think a big part of the world in which I practice for 40 years is still very male dominated. And since men don't have any hormone shifts, it really doesn't occur to them that other people do. And not to criticize all men, but when you look at the lack of awareness of the demographic changes, for example, in 1800, the average life expectancy of American women was 32. So just after the American Revolution, pretty amazing to think that half of us were dead by 32, and only 5% of women at that time lived to be 50. So when you go back, if you're curious, you can look at the University of Virginia. They have all the early census data for the colonies and the early United States. So I find that to be amazing, as just a way to confirm that this is still a pretty new experience for humans to live past 50 by the millions. There are very few positive role models. I mean, I look at people like Gloria Steinem, she's pretty awesome. She's quite the role model. But when we look at age 80 and beyond, it's pretty tough. And I often give this homework assignment to my 45-year-old patients, because I'll say, okay, you know, you're halfway there, assuming we're going to live to be 90, which if you're healthy in 45, you very likely will live to be 90. So the homework assignment I give is between now and next year when I see you, see if you can find 5 women over 80 in whose bodies you'd be happy to live. And obviously that's pretty tough, even starting right now, because you don't see that many women at 80 today, meaning they were born in the 1930s or early 1940, who've really taken great care of themselves and who aren't so creaky or riddled with arthritis that they're, you know, okay getting up and walking, to say nothing of weight management, and diabetes, and high blood pressure, and strokes, and other things that tend to accompany older ages. We're busy. We tend to run right past ourselves, and we power through whatever annoys us, and we often don't really take the time needed to question what we've heard. So I touched on the average lifespan. You know, even 100 years ago, just think half of us lived to be 50, as opposed to 5% the previous 100 years. So half of us lived to be 50 pretty much. And then we added 32 years of life expectancy between 1900 and 2000. And so it's kind of fascinating when you are a literature nerd like me to really imagine what caused that increase in lifespan. So between 1800 and 1900, putting sewage underground, some pretty basic things, hand washing, those things helped. In the next 100 years, that's when we got immunizations. And we also developed antibiotics, surgical techniques, revascularization of the heart for people with bad atherosclerosis, the coronary artery bypass graft. All these fancy surgeries have extended the lifespan of many people. Yesterday, I was in my car listening to NPR, and they had a pretty heartbreaking series of interviews regarding loss of limb, meaning amputations. Of course, the most common cause of amputation is diabetes and high blood pressure and high cholesterol. So blockage of the arteries that feed, branch off the aorta. Anyway, and just, when you spent time in training at VA hospitals and you see contributions of smoking, there's still people who smoke today. And all these things, when we throw into our lifespan, it isn't necessarily a health span. And my big concern is that there really has not been a genetic change to adapt to a 30-year lifespan in an estrogen deficient environment. So I like this image because it's from the late 1800s. And, this was the arc of a woman's life. And of course, she would be married sometime between age 17 and 20. If you were 26 and you weren't married, you were an old maid. So, we're definitely not replicating that any longer. But when you look at the actual healthy lifespan, then you see women bent over, and they're bent over because of osteoporosis. So another sobering fact, if we live long enough in an estrogen deficient environment, we will all develop osteoporosis. And so 70, 80, the very few that live to be 90 or 100, and you can see this is sadly the Ruth Bader Ginsburg look. And, I thought it was tragic that she obviously had such terrible osteoporosis. She clearly had an incredible mind, but it would have been nicer for her to maybe not develop all those fractures in her spine. So here is a picture kind of from a scientific view of your sex hormones from birth to age 83. And women are the red lines. So here are baby women, baby females. And then we have our estrogen bump up when we adolesce, and it stays at 100% of sufficiency pretty much until we're headed into our mid 40s. And then as we go through menopause, our estradiol decreases, and of course the ovaries never wake up again naturally, and so we become estrogen deficient for the rest of our lives. And that's why we continuously will be losing bone in a low estrogen environment. We'll talk about likely why the body would even have a mechanism like that. It seems kind of ridiculous because it clearly isn't good for us in terms of vigor to be constantly losing bone. Then a little sneaky red line down here is actually our testosterone level. And most women have never had their testosterone checked unless they had very irregular cycles, and a doctor may have been thinking about polycystic ovarian syndrome, where actually those women tend to have a high testosterone compared to normals. But the point here being we have a little bit of testosterone, but it's a crucial little bit. And then that little bit also pretty much runs out. So we are both estrogen deficient and androgen or testosterone deficient. Whereas men, the boys are in blue, little baby boys, by the way, these hormones are from your mom, you get them through the placenta, and then boys adolesce, and then men have a continuous production, as long as they have testicles, of testosterone through age, last data point here is age 83. I think this is incredibly important because men, of course, when you think about it evolutionarily from a fertility standpoint, they mostly can help produce offspring their entire life if they so choose. if they find a female partner who's fertile. What's also important, so basically maintaining hormonal sufficiency to support spermatogenesis, to get basic in the biology sector, that makes sense. Okay, so what about men's estrogen level? Well, you can see that in fact they have a pretty continuous estradiol, the most powerful estrogen, their whole life. It goes up a little bit as they age, probably from a little bit more body fat. But every time I've given this slide in a talk to doctors, 100% say, oh, wow, I did not know men had estrogen. And so just the fact that they make that comment, I find as just further evidence that the medical people that my patients, we consumer females send counter, are not thinking about this at all. So I'd like to just take a little step back and say, well, what's an estrogen? What's estradiol? What's Premarin? Because these are all words you've heard. So estrogen is a class of the female dominant, most important hormone. And before we had chemical synthesis, Premarin, pregnant mare's urine extract, was a fantastic symptom reliever. And even today, Premarin in head-to-head trials started in young women. It's equally effective as estradiol, the bioidentical, in relieving hot flashes. And it also does a beautiful job preventing bone loss. It's been available since 1942 as a cream or a little pill. It comes in various doses, but this is the only estrogen that was studied in the Women's Health Initiative that was released in 2002. And the importance of knowing that is that the Premarin given there was one dose, 0.625, and it's all by mouth. And the average age, which I put here in this little black box, was 63 and a half. So from this data set with thousands of women over 70, in fact, who were not on hormone therapy and then were put on hormone therapy, these conjugated equine estrogens, CEE, otherwise known as Premarin, caused a greater tendency to form blood clots, and the blood clots that lodge in the brain are called strokes. The blood clots in the lung are called pulmonary emboli. Blood clots that stay in veins in your leg, that's a thrombosis in the calf or in the thigh. But that's really where, quote, estrogen got a bad name. From the cardiovascular standpoint, we say oral conjugated equine estrogens create increased clotting, or it's called increased thrombosis. So again, it is, in the past, it was the most common formulation of hormone support in menopause, because in 1942, when it came out, it was fantastically successful at relieving menopausal symptoms. And as long as you started it when you were young and symptomatic, it actually, even to this day, is clearly promoting better health, less diabetes, less high blood pressure, fewer heart attacks, in fact, fewer strokes in the women that started early. These are teasing out very important details that no one knows except a few of us who are actually menopause experts, and we separate out the various products because it matters. And I say hormones are like breeds of dogs. You know, they have a different bark and a different bite, and some are gigantic and some are little teeny ones, and hormones are like that. It matters which one you take and the route by which you take it, either by mouth or through the skin. The fact that they used Premarin in combination with a single progestin, meaning a synthetic hormone, that has actions very much like natural progesterone, but not exactly. They used medroxyprogesterone acetate in those combinations in the women with a uterus. So there were two trials, one women who had a hysterectomy, about 12,000 women randomized in that group, and then about 26,000 who still had their uterus who were randomized to the Prem-Pro group, so medroxyprogesterone acetate and Premarin. And I give you these details because this is the Premarin molecule, the most dominant equiline or horse estrogen. It is not the same as bioidentical estradiol. And these are the covers of Time, Newsweek, and US News and World Report that came out in 2002. And you would think that we would have corrected this misperception and all the panic that was generated. But because of the black box warning, which persists on every single estrogen product, and for those of you who have ever opened a package insert, even on micro doses of vaginal only estradiol, which we know does nothing to the blood system. It does not promote clotting. In fact, it doesn't get to the brain or anything else. We use it in breast cancer survivors with estrogen receptor positive metastatic breast cancer. So we know it doesn't affect their systemic body, but those vaginal suppositories also have the black box warning, as if it's the average age 63.5-year-old woman taking Prem-Pro. So that's a big problem because discerning people, otherwise known as women, read the package insert, and most doctors don't have time to say, you're going to see this black box. It really doesn't relate to this product. Believe me, don't worry about that. But people say, well, why does the FDA still have that black box? There's a lot of politics behind that. And I can tell you, we're working very hard to get rid of it because it's a huge problem in the United States. And unfortunately, because of our WHI in the US, we have affected adversely women throughout the world. Bioidentical hormones, and here's one hydroxyl group. There's another one hidden behind Synergy PT, but estradiol and OH is hydroxyl, and that's where the name comes from. So we actually know exactly the chemical structure, and we've been able to synthesize these in laboratories. They're usually made from plants, either clover or soy, because the plant estrogen-like compounds in those are very easy to fiddle with for the chemists in the lab. So all bioidentical hormones come from a few laboratories that really, I visited them. They look, these pharmaceutical synthesis houses look like you're on the moon. Everybody's wearing spacesuits and this elegant equipment that's usually made in Germany or Italy. And it looks like giant cappuccino machines. Anyway, so wherever you get your quote bioidentical hormones, they're made in very few places because it's pretty complicated. In any event, estradiol is the dominant hormone in our body that relieves symptoms. And then we interconvert, and I gave you the names of the other estrogens that we naturally interconvert. So if we give estradiol through the skin, we do the same interconversion. About half of that lives as estrone with one hydroxyl, O-N-E, and the about 3% is turned into estriol. And estriol is an estrogen that's particularly elaborated inside the pregnancy. So we have higher estriol levels in pregnancy than we do any other time in our lives. As I said, about 3% of our estrogen is estriol, and the other is sort of 50-50 naturally estradiol and estrone. Progesterone is the name for the natural progesterone made after ovulation in the ovaries. And then testosterone, women make about 2/3 in our ovary when we're younger, and about 1/3 in the adrenal gland. So that's why you saw the testosterone level go down and then a very slow slope as it goes down further. And that's because adrenal production declines also with age. So estrogen in general, we know now, and we have tons and tons of literature from all around the world that shows starting estrogen early, meaning when you first enter menopause, compared to women who don't take it, we will have less heart disease. We will not lose bone as long as our vitamin D is sufficient. We'll exercise, adequate calcium in your diet. We now know, no question, that estrogen is neuroprotective, and women who are on estrogen have much lower rates of cognitive decline and development of dementia. Of course, all the other things that we're normally used to, like having sufficient moisture in the vagina, being able to have intercourse if we wish without it being, the vagina being too tight or dry. These are all things that estrogen does so simply. Something that's really common, and again, it's in the literature. There was a great article in the New England Journal about 5 years ago written by an ophthalmologist who was basically saying that every ophthalmologist needs to practice with a gynecologist, because he started seeing all these women in their mid-40s who were complaining of dry eye. Well, tear production is an estrogen dependent function. I mentioned that in that little Bioidentical hormone book. But because medicine has become so siloed, people aren't thinking about when your last period was. I haven't even put on this list the arthritis increase in often perimenopausal to menopausal women, because that's what you often will be seeing in these women where, they get quote tennis elbow without doing much of anything, or knee pain, often hip pain or stiffness. Intervertebral disc fluid actually decreases in amount with chronic prolonged estrogen deficiency. So we know orthopedically there are many things I could have added to this slide. And what's also important for all of us is to just inquire, well, when was your last period? Which many times I've met women who've had the comprehensive arthritis workup for autoimmune disease and this and that. And then finally it dawns on the internist or the family doctor, oh, wow, your last period was 2 years ago. Well, maybe it's estrogen deficiency. Well, 100% it's estrogen deficiency if your last period was 2 years ago. And then lastly, how we take it really matters as we get older. So younger women, especially women who've been on birth control pills and they were fine, or birth control hormones like the NuvaRing, they can safely take their menopause hormones through the mouth. But as we get older, probably at least by 65, we should encourage women to take their hormones through the skin, not by mouth. So most of us know that our menstrual periods are basically generated by the rise and fall of estrogen and progesterone. We get a peak around ovulation of our estradiol, and then the ovary will ovulate and produce progesterone after ovulation. And if we don't get pregnant, then as those hormones decline, the blood supply to the uterus basically retracts, cuts itself off, and that's really what our period is. Testosterone cycles a little bit up and down during the menstrual cycle, a little higher in the middle, probably helps with libido a little bit, so we're a little more likely to get pregnant. Again, that's sort of been nature's goal, is reproduction. And I say consciousness has evolved as well, and so that may not be the goal of a lot of female humans. We have different drives today, and that's where I think the evolution of consciousness is what we can enjoy, but our biologic evolution is pretty finite. And I think the more we appreciate that, the better we will prepare ourselves for what's coming. You'll have many doctors say, well, don't even check your hormones, just go by symptoms. That's actually true. On the other hand, it's very helpful if you see that your FSH, like a woman I saw this morning, her FSH was 88. At the moment she had her blood drawn, her estradiol was 45. Well, if it were 45 all the time, her her FSH would not have been that high. Normally, when you're young and fertile and not thinking about hormones, your FSH, follicle stimulating hormone, is about 10 or less. So generally, they're like a seesaw. If the FSH is high, it means estrogen is low. And the very name follicle stimulating hormone is to get those follicles in the ovary to make estrogen, and it's coming from the brain. That's where the signal comes from. The hypothalamus, which would be the intersection behind my nose and kind of middle of my ear, is a temperature regulating center. And it interprets a lot of things, and it puts out the FSH signal to the pituitary, and then the pituitary is the one that's telling ovaries to get cracking and make the hormone. So it's an elegant cycle of auto-regulation until we hit menopause, at which point the ovaries can't respond. By the way, I use that picture of muscle because muscle building and maintenance is also estrogen dependent. And probably for some of you who've been in either physical therapy or Pilates teaching for a long time, you can watch women age. I remember early in my practice, I looked at the shoulder of my patients when I would examine them, and you could just see the women who exercised, who were on estrogen, and the women who weren't on estrogen, because you could just see how the actual muscle volume around the whole shoulder girdle was diminished. And of course, what do we see all the time? All kinds of rotator cuff injuries. So I try to help my patients get active, get a good prevention program of strength and flexibility when they're younger, so they already are basically developing good self-care habits, so that with estrogen support, they'll maintain as optimally as possible good, healthy connective tissue and elasticity, and avoid so many of these tears and repairs that we see all too commonly. Very common, way before you actually missed your period, is to have these lousy sleep nights, waking up, 2:30 or 3, maybe hot, maybe sweating, but mostly very alert. This concept of brain fog, where are my keys? Word finding just not as sharp. This is a very common experience and complaint. And especially so many women that I see are very high powered in their job. I think the Zoom meetings all the time, not taking a break, the brain just gets so tired. And if you've had poor sleep and you already are estrogen deficient, your whole replenishment of neurotransmitters is impaired. So these things, it's not like we're looking for trouble. The trouble comes out and bites us. Many mood disorders appear in menopause. Again, as I said, postpartum depression, but also women who've had bad PMS tend to have a more rocky menopause. We talked about the stiff joints and arthritis. Libido, decreased desire for sex, is definitely, at least in part, fueled by not enough of your hormones to support it. It also helps to have a partner that you at least like. So many of the relationship issues that women have dragged along, they get pretty intolerant by age 50. It's like, okay, if I'm at least the halfway point, I want my relationship to shape up. So there are many reasons to have decreased desire for sex. But all these issues aside, definitely having hormone deficiency doesn't help. And lastly, just lack of energy in general. So there's a big research, and you may have read about it, it's kind of exciting, about extending the lifespan of ovaries so that we would have natural endogenous synthesis of our hormones for many more years. And the Buck Fund in Marin County, California, has a giant grant devoted to this, and they're looking in many facets of what actually codes for aging. If you're interested, this woman, Elizabeth Blackburn, Blackburn, she's a Nobel laureate. She discovered telomeres and telomerase and aging as it's coded for by the shortening or protection of telomeres. That's how you spell telomeres. So we know that these elegant processes exist. And the bad news is that estrogen deficiency accelerates aging. And what's so fascinating to me, that was basically the gist of this Wall Street Journal article yesterday. I'm sure most doctors don't read these little health reporter entries, but if you read the neuroscience literature, which I have for about 25 years, it's sad. It's not on the conscious list of concerns for the vast majority of internists, family practice doctors, or especially gynecologists. We're very siloed in our knowledge, but we know that every cell in our body, in fact, is estrogen dependent. And now we have research, you may have heard the mitochondria, the powerhouse of the cell. All the processes in the mitochondria are also slightly less favorable in estrogen deficiency. The special sentinels that help maintain membrane integrity for this entire, quote, cytoskeleton, they become impaired. There are special receptors on the cell surface that bring in nutrients and put out waste matter. This is every cell in our body. And a lot of these are directly impaired, and we can measure the degree of less optimal function in estrogen deficient tissues, whether it's brain. And of course, I pulled that slide together for a talk that I was giving, but that could have been a neuron, except that we like to see all those dendrites spreading out in the brain. But the basic cell mechanism of aging is accelerated in estrogen deficient environments. We've done this work in animals, in rats, mice, and dogs, and actually monkeys and other primates, non-human primates. We know that blood pressure and cholesterol go up. Well, why is that? Partly because of lack of elasticity in blood vessels, that same thing, elasticity of the vaginal entrance tissue. But in addition, in the heart, estrogen induces the synthesis and release of nitrous oxide in the arteries. And nitrous oxide helps arteries expand and give less resistance. So that keeps blood pressure lower when you have better compliance. So, you know, it's very straightforward why it would be that women who are estrogen deficient generally have an increase in both blood pressure and therefore heart disease. Bone loss, we talked about, that probably is a holdover from the fact that we would increase mobilization of calcium and protein from bone when we nurse babies. So again, much of our biologic selection pressure evolutionarily is for reproduction. It's not for living in a healthy, vigorous way after age 50. Then lastly, the mind-body connection. If you measure resiliency, which is kind of a psychiatric term, but resilience is diminished as women age, and it's both biologically diminished, but also psychologically diminished. I also like to just point out that really what kills us is not breast cancer. You can see about 2.4% of women die of breast cancer, and about 60% of us, the approximate cause of death will be heart. And amazingly now, 30% of female deaths are attributed to dementia of one type or another. This picture is taken from one of Elizabeth Blackburn's slides. And I love it because it kind of looks like a skein of yarn, but that just shows you where the telomeres are. They're the orange ends of these chromosomes. And you know how chromosomes are paired and they match in the middle. And telomerase and all these things are very stress and estrogen dependent. So stress shortens telomeres, estrogen deficiency shortens telomeres. So both accelerate aging. Here are concerns. I'm not telling you anything you don't already know, but I do think the beautiful thing is we now know what we can do about it in a healthy way, as long as we also know that estrogen does not increase your risk of breast cancer. And in fact, there 22-year data analysis from that original 2002 study. So when it was released in 2002, by the way, that was about a 7.5-year data set. So in 2020, they released the 22-year data set and analysis, and the women on estrogen only actually had about 20% less breast cancer, but they had a 50% better survival rate if they got breast cancer than as compared to women not on estrogen. So these are the facts, how we get them out in a way that exceeds what we've seen in the newspaper or women's magazines. Our breast center here at CPMC, over which I have no control anymore over what gets mailed to patients, they list estrogen use as a risk factor for breast cancer. That is not correct. And even if you're on Prem Pro, the quote bad combination, the absolute risk difference was about 6 more cases of breast cancer in 10,000 women years of use, which is clinically insignificant number. So, you know, knowing the data and being careful about it and accurate is a rare thing in the medical culture, but it's a virtually never thing in the dominant lay culture. But this is the data from the Women's Health Initiative that was published in 2020. And, you know, virtually every single patient I see says, how come my other doctor didn't say this? So I used to just shrug my shoulders. Now I just say, you know what, sadly, most doctors are so busy, they just don't have time to read the literature. And I read the literature, and I consider that part of my job, even though I can't do it during business hours. I have to do it on my own time, but I enjoy the literature, and I think it's important, and I want to make a healthy difference. Simply in our slide set, and this is available to all of you who want this, I wanted to give a tool so that women know what they should bring up at an office visit. So on the left-hand side comes from us. When was our last menstrual period? What are our periods like? Because often they're skipping around. They haven't totally stopped. How's my mood? You know, being honest. Am I having lapses of memory? What's my sleep like? All these things. And then, of course, there's this group of women, and about, interestingly, across the country, almost 40% of women wind up having hysterectomy. Guess what? It's much less on the coast. It's less in California. It's less in New York. It's a lot more if you're in the southern states. Not surprising somehow. But anyway, if women don't have menstrual periods to guide them, then their symptoms are 100% of what they need to pay attention to. So getting some blood tests together, these are things, if you're lucky, I said you can also ask for testosterone. I'm a tremendous advocate for annual mammography after 40. There's plenty of data to say we don't just save lives, we save breasts, because a woman who's screened annually is much more likely to have a very small pre-invasive lesion and is often cured by just local excision. And lastly, bone density. If we have a family history of osteoporosis, very helpful to know when you're going into this change of lifetime. Oh, did my mom have osteoporosis because actually she was a vegetarian, she never drank milk, you know, whatever. So there are many reasons that women may not have reached peak bone mass. Women who've been anorectic often have osteopenia, severe osteopenia, entering menopause. Women who've been super athletes getting stress amenorrhea with stress fractures when they're younger. I see this in distance runners, not infrequently. So to know where we're starting, again, is to motivate clinicians to see the big picture. By the way, the national standard still, baseline bone density, baseline, like the first one, age 65. That makes no sense if we want to prevent osteoporosis and fracture. Low vitamin D, by the way, is a very common reason for osteoporosis, actually, because if vitamin D is less than 20, we cannot absorb calcium from food or supplements. So many people have never checked their vitamin D. That's a very helpful, easy thing to put on a lab slip. this very detailed questionnaire you can pull up. This is the direct link. And these slides are not PDF. So if you click on that link, you actually go to the website and you'll pull up this menopause specific quality of life questionnaire. Very simple, very helpful. And again, this is homework before women go to see their clinician. And the standard care actually is to prescribe estrogen for relief of symptoms. That was the point of the Wall Street Journal article, that instead of 3 or 4 different drugs, just restoring a woman's estrogen level to a healthy, sufficient minimum cures all of those symptoms and does a fantastic job with primary prevention, heart disease, dementia, osteoporosis, diabetes. By the way, diabetes, the difference between users of estrogen and non-users by age 70 is a reduction of 45%. So these are very important from a public health standpoint. Loss of muscle mass, sarcopenia, these are all prevented by estrogen. We'll still lose a little bit, it's interesting, but it's a very subtle change. And there is no data that says when one should stop. And virtually all the women in my age group and colleagues older than I, we all say, you know, I will die with my patch on my skin or my estrogen ring in, whatever. You know, the joke is my hormones will be in my cold dead hand. But of course, I try to convince my patients that it is a little healthier, even if you're a healthy, vigorous lifestyle person like myself, it's still healthier to go on transdermals after a certain age, 60, 65. And just probably the most controversial thing I'll say, but it's an area of my expertise, ductal carcinoma in situ or lobular carcinoma in situ is not an absolute reason to not be on estrogen. And we know this from very large data sets from women who were diagnosed with those disorders when they were still young and menstruating. So there's not a standard of care to remove ovaries or cause what we call chemical menopause in women who have those precancerous changes that are usually found on mammography. So I say that's the most controversial thing I'll say because people call that breast cancer, but it's really pre-invasive disease. And when you look at longevity and what women die of, we have huge data sets for these populations of women who've been deprived of estrogen, who've died of heart attacks and strokes and other cardiovascular causes. So that's basically the summary. And I'd like to have time for some questions. And I welcome discussion and anything anybody wants to bring up. Yes, Elaine.
I started hormone replacement therapy because of musculoskeletal issues. I did not start it at menopause. I've been on, I believe it's probably, geez, I have to look back at my records, probably 13 years, maybe more than that, 15 years. And what happens between those years when I've been deprived? Because I noticed the difference in my physical body, you know, dry vagina, less sex drive, and muscles. Those were my symptoms. I didn't have anything else, but I'm curious about the internal mechanics, not the symptoms, but how is my body adjusting now having hormones where it had a pause?
It's interesting. So there's actually pretty accurate information to answer your question in what I call a sexy way, meaning specific to you. So a fantastic author, and you can look him up, Richard Santon, S as in Sam, A-N, T as in Tom, E-N. There are several of his lectures on the web, but he is a particularly fantastic reference, in my opinion, because he talks about cardiovascular age or cardiovascular health. And when we put women on hormones or on estrogen who have had a hiatus. So the woman who's had a healthy lifestyle, normal blood pressure, normal to high normal cholesterol, who's taking good care of herself, that woman, we really consider her cardiovascular age as a young woman. And so it's sort of neat to see his articles in the New England Journal, but also if you go to YouTube, there are several talks he's given where, he's got great slides and really explains it in ways that, although it's pretty sophisticated, these are for medical conferences, but still you see how much is known. And the specific answer I would give you, Elaine, is that we happily will improve our bone density at a rate which we even know. I'll show you my little graph that I have in my pocket that I show patients. So on the far right-hand side, your right-hand side of the screen is the gray that goes down. That's women on nothing. They continue to lose bone. But you can see the lower doses are over on this side, and then the higher doses go that way. So estrogen restoration of bone is a dose-dependent function. So you're gradually improving your bone density. It's really kind of fun for me because I get to show women on their serial bone density measurements their gradual improvement. And by the way, the orange bar there, which is about 5.8% improvement over 2 years at the spine, that's the same as bisphosphonates in 2 years, bone building at the spine. Again, my preference is for the natural hormone that did a good job keeping us in balance to restore that. And in women who have very low bone mass, of course, that's a pretty easy thing to measure, then I tell them you might want to consider, at least until you're out of the woods, of your osteoporosis, to be on the higher dose, even if you don't need it for vaginal health or libido. But it certainly helps you build bone faster. The other thing, which is also true, is that 0.1, the higher dose patch, which was that orange bar, that is the dose recommended by the neuroscience community. So, one day I'd like to have the conference that's, in fact, our Menopause Society this fall will have about at least half of the meeting is just the neuroscience of hormones and the brain, to really embolden gynecologists to not be so stingy. I see a lot of patients whose doctors gave them a 0.025 patch. Well, that prevents bone loss. You could see, those women they gain about 1% in 2 years. So it halts loss. But if you're already in deficit, you'd rather build bone a little faster. Anyway, but for the brain, which to me is sort of the commandeering dominant choice, definitely the higher doses are better for brain. So the last part to answer your question, Elaine, is for women who've been off of estrogen for a while, I always encourage them to take it through the skin or through the vagina, because we don't want to explore whether or not you individually are at increased risk for a blood clot. And any bioidentical estradiol by mouth or Premarin by mouth, it all increases risk slightly. But why increase risk? If you give it through the skin, you don't increase risk. It's just like your ovary made it. So that would be my answer. And I say, good for you. And of course, what's amazing for the creaky women is usually it's about 3 months and their joints are better and they're a little less in pain. So Roberta, you have a question.
Thank you very much for your presentation. I do have a question here. On your slide, pre-invasive breast disease, DCIS, not enough to avoid estrogen. So I have, and what do they call it? ADK or something like that. And a papillary.
ADH, probably atypical ductal hyperplasia.
Yes, and papillary lesion. And I've been on the estradiol gel and Prometrium for a number of years. And of course, they're all screaming at me to get off of that. And I've been sort of tapering like every 4th day or something. So I'm curious about that. as soon as I say HRT, they all jump up and down and say, oh, got to get off of that. Got to get off of that. And I don't know. I mean, I'm not electing surgery. I'm electing to watch C. So I don't know. I'm thinking that why not just stay on the estrogen and the prometrium so that they're at least balanced.
This is exactly the hot seat where I live. I live in exactly this hot seat because this is the view, breast lesion. That is not all of you. And of course, the tragedy in my view is if you look at death rates, all the tamoxifen in the world, and this is a truth. Okay, you may have a lower risk for DCIS or an invasive breast cancer if you take tamoxifen instead of your bioidentical estrogen, but you don't have greater longevity and you have a lot more morbidity, meaning accumulation of risk. Now, you're slender, you're not the average woman. I like to tell patients, look at these body mass index charts online. Look at what you would have to weigh to have a BMI of 28 and a half. That was the body mass index of the average woman at entry into the WHI. So I look at my 5'2", I would have to weigh about 157 pounds. I weigh about 120 pounds. Okay, so 157 is another third of my weight. That's what they were looking at in the WHI. Older women and mild obesity. Those women at the end of 7 years, their BMI was 30. So you and I, and virtually everybody I saw on this webinar today, we're not in the WHI. So don't use the data for overweight women who have a tremendous amount of inflammatory change going on because of their fat mass. Anyway, so I would say with courage to you as my individual patient, prescribing the probably estrogel for you is probably your gel that you use in your pump bottle. You're actually on a moderately low dose, natural progesterone. And again, the data for natural progesterone comes from the French. The French have a teachers study and electrical workers study. These two are very much like our nurses' health study, giant observational data sets of bioidentical estradiol, mostly 82% through the skin. That's what French women do, and natural progesterone.
So prometrium, is that considered natural?
Prometrium is like bioidentical progesterone, yes. So, that data set, observational data set, shows much better health. Once again, but what's crucial to you, and depending on the breast center, believe me, I do tango with these people every week. I'm definitely a contrarian. Why? Because I look at the whole woman and I look at your quality of life. I don't want you to have more biopsies, but you know what? With ADH, and then I would, if you were my patient, I'd say, what's your breast density? Are you lucky? Do you have low breast density? Is it easy to reach your mammogram? Do you have high, extremely dense breasts? Then those women deserve an MRI. Do you have a family history? So there are many things that go into the conversation. I'm not just like, oh yeah, take all the estrogen you want. But when you look at the data sets for what our quality of life is and what we die of, we actually have a shorter health span by far because we accumulate other disorders, and generally a worse quality of life. So if I have ADH someday, I'm happy to have my annual mammogram. I have heterogeneous breast density. That's what most women have. As we get older, we tend to get more fat. So our breasts tend to get less dense, even on estrogen. But these are the things that I think it's important to know the details and to be confident that we can learn these details and respond to them appropriately. So the most important thing for you, since atypical ductal or atypical lobular hyperplasia, these are not things we'll ever feel. We only pick up these subtle atypical changes by mammography. And I like to use my pap smears and abnormal pap smears and having a little dysplasia or HPV. Okay, it's easy to put a speculum in gently. Look at the cervix. Oh, I see the little area. Little local anesthesia, snip it off. No big deal. If we had the same attitude towards ADH or ALH, it would be a different world. But because we are so siloed, and even gynecologists, I think we're among the worst, because we're absolutely like in a rush all the time. The average GYN visit's 15 minutes. So, I mean, I wish I could take care of the world. I can't, but it's why I love to give information away and be accurate about it.
You put a papillary lesion in that same category?
Yes, calling it papillary just is a description of kind of these sort of more branching areas. In fact, probably over the next 5 years, we're going to change the whole nomenclature about breast diseases. It's going to drive everybody crazy, but you know, I was just at the breast meeting in March, and my favorite guru is a man in Sweden who really is the guy that, you know, brought all the data of mammography reducing death rates from breast cancer, because in Sweden, since the late 1970s, all the counties of Sweden, which are like our states, except for 2, the women voted, not the men. Only the women could vote whether or not they wanted screening or not. And so 2 counties, those women voted not to have mammograms. And so we have a natural history. Guess what? The incidence of breast cancer in those 2 counties has continued to rise. Of course, the population's older. That's the greatest risk. The counties that have screening, after about 10 years, the death rate from breast cancer has gone down and down and down. Anyway, it's beautiful when you see these elegant, determined, careful researchers, but it is in looking carefully now at a lot of what we call immunohistochemistry that we realize these anatomic descriptions of lobular versus ductal, that really doesn't make sense. When we look at the genetics of these various tumors, it's making more sense to call it cancerization of lobules, because it's basically the same cells that look ductal, but they're palisading it anyway. So I think, just simply said, if I had what you have, I'd stick my patch on, I'd take my progesterone. By the way, there is one other option that maybe intellectually is a little lower risk, which would be the levonorgestrel IUD. If you read about LNG, and then the literature like Google Scholar, it would be LNG intrauterine system, comma, breast cancer. We use that a lot in tamoxifen users because they have a little higher rate of uterine cancer. So anyway, we have a lot of data about preventing uterine cancer, which is what that does, but also it makes your data set, your expectations more like the hysterectomy population, because you have no systemic progesterone. And since the French didn't show a decreased incidence of breast cancer significantly, it wasn't increased, but in the estradiol progesterone, intellectually, the estradiol systemic and levonorgestrel intrauterine IUD, which lasts for about 10 years in menopause, intellectually may be a better choice. I mean, it's a choice I made for myself, but something that most docs also don't discuss.
All right, thank you everybody so much for hanging in there. Thank you so much, Dr. Pollycove. It's such amazing information. I wish I could have everybody stay for 3 hours, but we will. So if you guys have questions in the interim, you can email me. I will keep a running list, and then we can bombard Dr. Pollycove at our next 2 sessions with any questions that you have that weren't answered today. I hope that we will see you again next month. Same Wednesday, first Wednesday of the month at 12:30. So thank you guys so much for attending. Great to see you all. And I look forward to seeing you all soon.